Finish off the day with a subject that is not that exciting, to be honest, but I think it's a really important topic for us all to address and be aware of our treatment patterns. So my goal with our talk today was really to try and review the hot trends of the last 5 years in terms of pain management in the emergency department. Go over what an ALTO is, and hopefully answer the question as to whether low-dose ketamine analgesia is just a fomented fantasy or whether it actually exists elsewhere in the world, because I haven't seen it used here. In terms of disclosures, I don't have any financial disclosures, obviously, but I think it's important that we acknowledge kind of going into a talk like this, what your prior experience with pain is, because I think that informs how you actually end up treating pain. As for myself, I've had a number of orthopedic surgeries, and this has taught me that oxycodone is a horrible drug and absolutely launches me into another dimension in terms of nausea, vomiting, dizziness, and it doesn't actually treat my pain at all. I'm a big fan of nerve blocks because they've really helped me. So I know going into this talk, I'm already biased, so just keep that in mind. And then the other thing is, despite my multiple orthopedic surgeries, I'm for some reason still playing contact sports. So I like to think I have a high pain tolerance. So knowing those two things, take what I have to say with maybe a grain of salt. What my talk will cover is physiology. I really don't want to make it too painful, words, but we'll go over a bit of and hopefully cover a little bit of up-to-date literature on specific scenarios and pain theory within the last couple of years. We will not be talking about how to be an opiate-free ED. And we also won't be able to get patients down to zero pain. And then finally, the treatment of opioid use disorder, I'll leave that to another talk another day. It's a whole lecture in itself, and exactly actually already covered some aspects of that. Why am I covering this? I mean, Rosen says it really well. It's a really frustrating challenge to address. We have more than 40 years of literature stating that we're actually not that good at treating pain, both in terms of slow to react and underdosing pain. But the truth is that we how to be good at doing it because both physiologic, for a physiologic, there's poorly treated pain leads to bad outcomes, right? So sympathetic outflow leads to increased peripheral oxygen demand, etc. And developing pain and hyperalgesia is linked to poorly treated pain in the emergency patients. The reflex response to pain, but Rosen's covers it pretty well. And just to mention that whenever we're prescribing medications, we have to acknowledge that our medications that they are influenced by, as I mentioned already, your own personal bias, pharmacokinetics, pharmacodynamics, we have on clinical efficacy, lobbying, and societal impacts. And so 40, 50 years, even though for hundreds of years and have been proven useful for hundreds of years, and forth in terms of opioids are evil and they cause respiratory depression and lots of side effects, swing the other way and start using alternatives, and then realize that actually our alternatives have lots of side effects as well. I'm being told that it's a bit choppy. Can you?
Yeah, it is. I mean, I guess you can always just try maybe turning off your video. That might help. We'll see how that goes.
Working, I'll try to either slow down or some stuff. Anyways, the point is that estimate the side effects, or if you're a little bit biased in terms of the side effects, or you run the risk of undertreating patients. And if are not afraid of the side effects and you think are the go-to treatment for everyone, run the risk of having patients with too many and potentially lead to opioid abuse. Know that the contribution of emergency to the opioid epidemic is minimal. It's about 4% in the US. I think it was 2015 or 2016. That being said, we still have a role to play. And that's where the ALTO movement born stands for opioids. And this is where research, antipsychotics, antidepressants, cannabinoids has really come into favor. Basically, why are we so bad at treating pain? There's a multiple bunch of factors. Time, we never have time to actually see our patients when it's super busy, or sometimes we don't have time anyways. Dosing can be complicated. Nursing, paperwork, flow is mainly our priority. Pharmacy has to approve of our drugs, and if we want to do any nursing collective orders, and they have to be involved. And that's before we even get into patient factors. So obviously communication and language barriers are an issue. A lack of really validated, useful assessment strategies because patients never seem to calibrate their numerical pain scales very well. And although we feel confident in maybe treating acute pain, dealing with recurrent pain, chronic pain, so recurrent pain being like migraine syndromes or, low back pain, things that occur often, our main goal, trying to get them back to being functional, can sometimes be quite a challenge, and we can develop quite a negative countertransference towards these patients when we feel like we're not really helping them. And same goes for chronic patients. So this can be really complicated and really hard to do. The main point I'm trying to get at here is that we are trying to treat pain in as an individual, but we're really part of a system that's trying to work together to treat a patient's pain. And so in the last 5 years, there's been a number of qualitative studies that have come out looking at how we can improve pain treatment as a system in the emergency room. And so I don't want to take too long on these studies. It's mainly just to put it on your radar and just note that in the first one, the first study there at the top, that was a case study analysis out of the UK where they interviewed, I think it was 37 or 38 staff and a number of patients in Northern England, where they aimed to identify areas for intervention that were lacking formal evidence. And what they discovered from these interviews was that pain control was not really perceived as a key organizational priority. So for example, the nursing staff are held accountable for care indicators that would, such as time to triage within 15 minutes, but not necessarily how they were treating pain. And a certain lack of feedback on performance was prevalent. To bring it back home into Canada, we think that we're doing a pretty good job treating pain, but here's a quality improvement study. You might recognize the name Lucas Chartier, who gave us a talk on quality improvement, I think it was 2 years ago. And he actually spoke about this study and how he was doing it. But out of Toronto General, they were looking at their time to analgesia, noting that many of their patients were actually waiting beyond 2 hours to receive either an assessment or access to analgesia. And there was a notable discrepancy between the nursing perception and the time to administration. So when you ask the nurse how fast they thought they were giving the medication, they all perceived that they were doing a really rapid, great job. But when you're a patient sitting in pain in the waiting room, 2 hours is a long time. So there was definitely some area for improvement there. And through the root cause analysis, they managed to do so by adding pre-printed order sheets, creating a flag system appropriate for different stakeholders. They had some weekly targeted feedback interventions, and they managed to decrease their time to analgesia by approximately 30 minutes. So again, I don't want to dwell on this aspect of pain management, but it is something that is up and coming in the literature that we should be aware of. And certainly, as I'm speaking to a lot of future leaders of emergency medicine, I think it's important that we recognize that system flow in our departments must align with pain treatment goals, and that pain control really is a team effort. And although you as the physician have to be aware of the physiology and the dosing, and you have to have good pain treatment strategies, you're really not working alone on this. And we really should be working towards a routine assessment of appropriate quality indicators. Okay, I'm gonna kind of zip through pain physiology just because there's a couple of things that I think are useful to know, and I think it's important for us to know, not just morphine 5 milligrams and that's it, but how are our medications really working, and what's our role in preventing long-term pain pathway changes. So to make this like as simple as possible, and the Rosen's chapter makes it pretty painful at times. What you need to know really is that there's kind of 4 pain conduction pathways. The first being transduction or nociceptive firing. So you step on a nail, you have nociceptors that fire, sorry. That then transmits up the dorsal root ganglion and then transmit all the way up to the brainstem into the cortex. At the level of the cortex, this is an area of mystery still to scientists. There's integration with cognitive processes that are affected by factors such as cultural expectations, personality, experiences, underlying emotional state, and so obviously pain is going to be different for everybody. And then to add to that, the area where I put the little blue stars here is areas where that signal that stems from the nociceptor input undergoes modulation. And what that means is basically either the signals that the nociceptors are firing, that threshold for firing can be increased or decreased based on the chemical mediators that are surrounding that action potential. And the same goes for as it enters through the dorsal root ganglion, as it goes through the brainstem, and as it ends up in the cortex. Depending on what neurotransmitters and mediators are surrounding that area, you'll get increased responsiveness, cortical responsiveness to input. And this is the basis for peripheral and central sensitization, which is the mechanism for chronic pain, allodynia, and hyperalgesia. And why am I going into this? Why do we need to know about this part? Well, although the literature to date is not, specifically in the emergency room, is not that strong in stating what kind of role emergency physicians specifically have in preventing central and peripheral sensitization, there is a good theoretical basis and some literature from the anesthesia and from the surgical literature demonstrating that if you do not act at these various levels, so if you're not either using opioids to act at different levels to modulate, if you're not doing nerve blocks to modulate, then your risk of developing those long-term pain syndromes is increased. So it is within our duty to try and act on these things. I'm not going to go into this. This is in Rosen's just because I just put it there so that we're kind of all using the same language. I do feel obligated to, I mean, I'm doing a talk on pain management. I feel kind of obligated to talk about the WHO analgesic ladder and its principles. Everyone should be able to kind of, regurgitate these principles. Basically, oral administration preferred whenever possible, that analgesics should be given regularly enough to maintain pain control, and agents should be chosen based on pain intensity, and treatment of severe pain should be considered an emergency. I will add to that we need to assume that pain is present when tissue damage is apparent, even in those who cannot communicate. And so we're talking about trauma patients with obvious injuries. We're talking about elderly who fell down and who complained once about back pain in the trauma room, who then became delirious and cannot communicate their pain anymore. We're talking about children who are nonverbal, and so we need to really be on the lookout for patients who may be vulnerable. Again, so in terms of updates on the WHO ladder for the last, I think it was first came out in 1986 or something like that. And the original was like a 3-step ladder where you start with weak opioids or non-opioids, and you climb up in terms of intensity. What they did in, I think it was 5 or 6 years ago, they came up with this new revised version where it's now a 4-step ladder to include invasive and minimally invasive treatment. So those are your nerve blocks, and recognize that, you might, us as emergency physicians, we're going to start somewhere probably at the opioids in severe pain, and then we'll try to come down and add the adjuvants to kind of create our bottom of the pyramid. I don't find like this, it's like a nice theoretical framework, but there's some validity concerns in terms of cancer pain and chronic pain. So while this is a nice place to start, there's a much bigger, more in-depth discussion than the WHO ladder, but it is the foundation of modern pain treatment. The foundation of modern pain treatment that every emerge resident should know, and every resident in general should know, is kind of these basic dosing aspects. And I've made these mistakes myself. I've seen other people make them, so I felt, again, obligated a little bit to put this into the talk. But know that NSAIDs have a ceiling effect for analgesia, so I put the doses there. And you will see people prescribing doses higher than this, but it will be, or it should be, with the intention to add an anti-inflammatory effect that is beyond this particular dose. So you'll see rheumatology prescribing 800 TID or something of ibuprofen, but that is with the specific intention to add an anti-inflammatory effect. You would treat pain shouldn't really be going higher than these doses. Opioids, on the other hand, have an unlimited pain modulating effect, but is limited by side effects. And so the sort of common use is start low and go slow and titrate up to their to where their pain is. And so really the starting dose for morphine is 0.1 milligram per kilogram. But I see a lot of people start with like 2.5 or 5, which is okay in your elderly patients, just as long as you're going back and double checking, or you're prescribing a titrating dose upwards for the nurses be able to actually titrate. Because I don't know if it's maybe because I'm at the Montreal General right now, but I do feel like we undertreat pain a lot, and so I think I might be hyper aware of this. I've definitely been caught. I've been maybe caught undertreating pain because of the fear of elderly person who might be delirious, who I think the 0.1 milligram per kilogram dose might be too high. I'm just noting a comment by Josh. Maximum analgesic dose framework is useful, but fails to consider duration of useful analgesia. Ketorolac 10 milligram being an example. Yeah, good comment. So, yeah, so you have to be aware of the duration of your analgesia. So that's why it's important to understand your pharmacokinetics and dynamics. For chronic opioid use, make sure this is another area where we may be undertreating patients because we're afraid, they're on a they're on a fentanyl patch, or they're on, long-acting opioids, and I'm afraid to give them too much. What you really should be aiming for is 10% of their total opioid dose per day to be using as a bolus short-acting opioid. Or you can increase their long-acting opioid by 1.5. So if they're on morphine 5 Q4 hours, you can increase it to 7.5 and reassess in an hour or so and see if that's adequate. A neat little article I found was about assessing pain control in an adequate fashion. And so most people, when you ask them, how will you assess pain in a patient, we'll first ask the patient, do you have pain? And then we'll ask them how bad it is, and we'll either refer to a numerical scale or a visual analog scale. And that works well most of the time, unless you have, like I said, somebody who's got their pain scale calibrated maybe a little bit off. You know, the man cold that has a 10 on 10 pain from a sore throat or something. And then the sickle cell patient who is coming in with an acute chest syndrome who, you know, it's not as bad this time as it was last time, so I'll give it a 2 on 10. So just make sure you're using a relative difference. It's fine for patients to give whatever number they want, but just try to make it relative. And you can use that to go back after and ask them a question to try and compare. But what the article I'm referring to that was kind of interesting was after you've given that dose of opioids or analgesia, or if you're not giving opioids, how are you assessing whether or not that the patient's pain has been adequately treated? So this was the article in question. So I know I've done this a number of times, but you prescribe an analgesic, and as you're walking by or as you go back to see the patient, you ask them how they're doing and do they need more pain medication or something, you know, along those lines. And you take their answer to that as being dichotomous and appropriate to give you the answer as to whether their pain has been adequately treated. And the problem with that is that there are lots of reasons why someone might say no, thank you to more pain medication. So what this interesting, a cute little study done out of Sacré-Cœur, again, you might recognize some of the names in, I think it was 2020, where they asked patients who had more than 4 on 10 pain on a numerical scale, who had already received analgesia, and they varied the order of these questions, but they asked them, do you want more pain medication? Yes or no? Is your pain relieved? Yes or no? And how would you rate your pain relief? Between the two dichotomous questions, both had a significant difference in terms of pain relief. You can see a little bit more in the relieved group versus do you want more pain medication? But out of the people who said, I am not relieved from the pain medication I received, about 38% of them said, no, I do not want more pain medication. And out of those people, more than 80% were concerned about side effects. So, you know, this isn't like the most surprising study, but it just goes to show that, you know, we might have to ask more than just one question when we're trying to assess pain. And we might have to listen to the people who are not the loud ones complaining for more pain medication. So we do still need to talk to our patients, and we do need to ask more than one question. In 2020, we have to address our bias in how we treat pain control in patients in general. I would argue that even the most socially aware here can find themselves stereotyping populations at one point or another. We all do it. It happens. It's implicit. We have to acknowledge it. And there's been, you know, lots of evidence, both qualitative and quantitative, in Indigenous populations as well as Black populations in the US and in Canada that have gone undertreated because of stereotyping for their pain. So they wait longer to receive pain medication, and they are typically undertreated. Specifically with Indigenous populations in Canada, one recent example, I'm sure most people here would be aware of the example, but Joyce Echaquan was a woman who presented to Joliet Hospital with abdominal pain and filmed herself in distress and screaming and speaking in her native tongue, and was subsequently insulted and dismissed by the nursing staff who saw her, who believed her to be either inebriated or just causing trouble. when in fact, if the translated message she was saying was, I'm in pain, I don't feel well, and please don't give me morphine, I'm afraid of the adverse effects, or something along those lines. We don't know why she died, but she did die, and it's important that we recognize that, you know, we might not be involved in a case that kills somebody, but there are certainly examples on a day-to-day basis in our hospitals, and we have to be speaking up for those moments. How do we assess patients who are critically ill? I scoured the literature to see if we have something better than simply looking at how agitated they are. In the last 10 years, there's been a bunch of kind of rehashing of very similar types of studies with very similar types of scales. We know that patients who are intubated and who are critically ill do experience pain. But the best that we have is the critically ill pain observation tool, which is this. It's available on MedCalc, and basically you go by how agitated they're looking, how they're moving, their facial expression, whether they're biting on the ventilator or not. So you can use this tool, and developed at McGill. Very cool. I didn't know that. And the basic thing I'm trying to communicate to you guys here is that patients who are critically ill do experience pain, and so simply putting them on propofol and sedating them completely might not be the best strategy for pain control. You should be adding either an intermittent bolus or maybe a low-dose infusion of ketamine or something else. All right, I think I have maybe 20 minutes, so I would like to go through some of the more interesting ALTO movements. The ALTO movement, which is kind of, if you ask me how I would define it, it's supposed to be a philosophy or commitment to using non-opioid approaches to pain. First, before using opioids. It's kind of like a rebranding of the WHO ladder. But the major thing is that it makes an effort to integrate a workflow that really encourages non-opioid alternatives. So that means having nurses aware of the other options besides opioid, having periodic educational seminars, physicians, but for nursing and coordinators, etc. And so it makes kind of at least attempts at making a culture of not quite an opioid-free environment, but opioid alternative-friendly environment. So this is a big thing in the US, both in New Jersey State and in Colorado. They focused on kind of 5 different areas: fractures, MSK pain, migraine, abdo pain, and renal colic. And they have these protocols, a whole resource tools available online. They use a bunch of medications that we definitely don't use here. Lidocaine is one that we're, maybe I'm a bit hesitant to use, but I like to go through just a couple of these things through cases. So the first is Madame Ange Cassé. She's a 72-year-old, mild neurocognitive disorder and a history of delirium from urosepsis. She's had a previous allergy to morphine and very adverse reaction to Dilaudid in the past. And she's got a number of GI and cardiac issues that you've also heard that orthosurgery doesn't really like NSAIDs for fractures, but she's got GI and cardiac issues anyways, so you're not sure you want to use that in this case to help her pain. You gave her Tylenol, but she still has 8 on 10 pain, even though she's not moving in the bed. She's immobilized, she's sitting there, but she's just in so much pain. And so and when you ask her, do you have pain? She says yes. When you ask her, would you like pain medication? She says, yes, please, help me. On your way to go talk to your staff about what alternative to opioids you can use, a guy comes in the trauma bay, and he suffered a table saw to his dominant hand, and so he severed D1, D2, D3 off, and his thumb is hanging off by a thread. You initially go to reach for the fentanyl because he seems to be in a lot of pain, but he actually says no, thank you to analgesia. He admits to previous narcotic use disorder and was in rehab for a while. So he wishes no analgesia for the moment, but you really see that he's, you know, in a lot of pain, and when plastic surgery comes and manipulates his hand, he's starting to look very uncomfortable. So he says, okay, if you can find me some kind of alternative, then I will take that alternative. So at this point, I'm wondering if people feel free to write in the chat what they would offer this person or these people in terms of alternative pain management. So we can't really give NSAIDs. They already got Tylenol. They don't want narcotics. Block option. The evidence is, you know, a bit biased in terms of we can't. It's very hard to perform a blinded nerve block study, but the evidence is pretty clear that they do well for distal rad hematoma blocks, intra-articular injections for shoulder reduction, femoral nerve or fascia iliata blocks for hip. We have good evidence to demonstrate that there's decreased rescue analgesia, although when you compare kind of pain scales, it doesn't necessarily say decreased pain overall, but as a surrogate, we see decreased opioid use. Decreased adverse effects in terms of nausea, pruritus, things like that you would expect from opioids. Decreased length of stay, which is interesting and that we like. Decreased time to functional status, which is an interesting one. This one came out of one particular study that had emerged physicians doing a fascia iliata block in emerge, and then 24 hours later they had a pathway specifically developed with anesthesia who would then put in a permanent, well not a permanent, but they would put in a the same block but with ongoing with an ongoing nerve block in the area. It's relatively simple dosing. It's just varying levels of volume, 5 to 35 milliliters, depending on where you're doing it. And really, there's only a handful of medications you need to know: bupivacaine, lidocaine, depending on the area of the joint, how long you want it to last, etc. And of course, patient's allergies. But the major issue with this, major barriers, is really not having the protocols to support us, not having the nursing support available to support us, not having access to nerve block kits ready to go. So you're stuck kind of fishing around the emerge department for these things. I know the Jewish General has done a great job at getting some of these kits to be easily available. So kudos to them. And then finally, training is like the major issue. There was a little survey done out of from CGEM in 2020 that aimed to characterize the use of regional anesthesia across Canada. Unsurprisingly, they only had a 13% response rate from physicians across Canada, so 194 physicians. And they reported using regional anesthesia on about two out of every 10 shifts. 3/4 were interested in using it more often. 98% reported having ultrasound available, but only half of the people who had ultrasound available actually felt comfortable using ultrasound for regional anesthesia. And again, I'm extremely biased in this regard because I've had orthopedic surgeries and experienced the side effects of narcotics. And although it was really weird to have my leg numb for a day and a half, I totally I didn't use one narcotic and I felt great. And I actually felt like I've had surgeries on both legs, so I feel like I compare, but not really. But I would take the nerve block over opioids any day. And to push it a little bit further, 1/2 of the CAPE EM ultrasound committee actually thinks that having a formal nerve block or regional anesthesia curriculum should be recognized as curriculum of ultrasound. And I have to say, like, especially being part of the I would agree with this. I think it's a skill that is so useful to have. Residency is the best time to get it. Otherwise, you're stuck going to conferences and everything. And this is my plug to the chiefs of next year to please organize the regional anesthesia ultrasound procedure day for us. And of course, before we start using this more often, needs to have better integration into workflow, needs to have buy-in from probably anesthesia, that if we do a nerve block, maybe they'll need an ongoing nerve block or something later on, some kind of pathway to be built if we think they're going to be admitted, or maybe to have anesthesia come do nerve blocks in the emerge. Either way, it needs to be integrated into whatever the culture is at your ED. Nina says, on anesthesia, I was specifically told it was inappropriate for me to be an off-service resident to learn about nerve blocks. This is a culture clash we need to overcome. I agree. I feel like nerve blocks are used a lot more in the States in context of this ALTO. Okay, so you happen to be a resident who is not comfortable with nerve blocks and your 2 patients are still screaming in pain. What other options do you have at this point? I think I saw before in the a whisper in the comments. Ketamine? I have to say I was unconvinced or maybe afraid of ketamine until I took upon reading for this. And of course I had to chat with Ruben. So I sent Ruben an email and he sent me like links to over 20 studies showing safety and efficacy between 1996 and even beyond 2017 now, up to 2018, 2019, in a variety of types of pain, and specifically highlighting their utility in patients with opioid misuse or red flags for opioid misuse, patients who are poorly tolerating opioids or who have opioids that are ineffective for them, chronic pain who are coming in with chronic pain exacerbations, who are on really maxed out opioids, who are on the brink of respiratory depression, who need something else. And as much as hard as you're trying to be empathetic and deal with the other spheres involved in their chronic pain, you're looking at another option here. And then in terms of end-of-life pain, not everybody wants to be zonked out on opioids at the end of life. And so this offers another medication option to try. In fact, as of 2016, of course, Ruben's on this position paper from the AEM, but they've written that subdissociative dose ketamine administered alone or as part of a multimodal analgesic approach may be considered in the ED. That you can counsel patients if there's a high likelihood of minor but at times bothersome psychoperceptual side effects. This occurs at the higher dose of lower dose ketamine. And as of 2018, ACEP's policy is that at the appropriate low dose ketamine, no monitor is required. To understand how to dose ketamine, people kind of use the argument that, oh, it's so easy to fall into that partially dissociated state, and then what do I do? Then I'm stuck either giving them more ketamine to make sure they're fully dissociated and not uncomfortable, or I have to give them something else to wait for them to come back down into the analgesic dose range. The reality is that if you're taking your weights, if you're being deliberate in your dosing, then you shouldn't ever really fall into the partial dissociation. You might venture into the recreational area where they feel a little loopy or wobbly. They might see the walls move a little bit or something, but then you back off on your dosing and they should fall right back in. Here in the dissociated areas where you do your procedural sedation, RSI, tranquilization, asthma control, but we are getting nowhere near that. That's around 100 to 200 milligrams. Way down here at the analgesic dosing range, you're doing somewhere between, in the literature, they state between 0.1 to 0.5. Ideally, you're more around 0.25 to 0.3 milligrams per kilograms. So what that means practically is the same way we do 50 micrograms or 25 micrograms or 75 micrograms of fentanyl, you're doing the exact same thing, 10, 20, 30 milligrams. They do not need to be on a monitor for this. The risk of experiencing recreational or dissociative effects is higher if you give it as a bolus, less likely if you give it over 10 minutes, and even less likely if you give it as a loading dose and then as a drip. And you can titrate this to your effect. What does our Canadian colleagues have to say about this? Well, there's no position statement, but they reviewed a meta-analysis on this a year ago, and they essentially make the exact same conclusion. The only thing is that they suggest that there's a much higher likelihood of psychoperceptual effects, but again, 0.3 to 0.5, the higher you get closer to that 0.5, the more likely you're going to have those effects. So back off to that 0.1 to 0.3 range, and you're less likely to have it. I think I have 5 minutes left, so I think I'll do, this last one here. So I'm a fan of ketamine. I haven't tried it yet, but I think I'm a fan. So I'm hoping I'm going to find some staff who will be happy to try this out with me, but we'll talk about that at the end, I think. The last kind of case I want to talk about is Mr. Resistant migraine. I actually had this specific case. I had the hand case I showed you too, but I had this specific case of migraine who told me he took 6 milligrams of sumatriptan already. It's his second visit in 3 days for headache. He's super stressed at school. He got Tylenol already. He got his ketorolac dose. He got his Maxturan, his liter bolus. He got his dexamethasone, his DHE yesterday. And now he wants to know, is there any hope for me? Do you have anything else? I Googled it and I read about nerve blocks and intranasal ketamine. Are these options for me? And actually he told me that he went to the Jewish, and at the Jewish they said, oh, they do ketamine at the MUHC, so go there. And so I felt bad when I said, I honestly don't know. And my staff laughed at me when I said, maybe we can try intranasal ketamine. So starting off with the blocks, I'm wondering if any of you guys do this. The evidence honestly is all over the place. Occipital nerve blocks, there's been evidence for the last 25 years. Whenever I've used them, they've seemed to work well. I've done them on kids as well. But when you actually look at the evidence, there's like 4 or 5 RCTs that are relatively recent, showing kind of equivocal results, lots of positive retrospective studies, lots of bias in these studies. It's hard to do, a good blinded procedure on a blinded study on these. There's some kind of, there's 1 or 2 kind of sketchy sham studies that seem to be positive. Again, they're easy to do. They don't take very long. You do not need to be an expert at anatomy for this. You just feel the occipital protuberance and then try to find where their pain is the most. And usually that's where the nerve is. And then you just put in a couple milliliters of either lidocaine or bupivacaine. With the caveat, obviously, infection, etc., all risks of any procedure. Sphenopalatine block, on the other hand, again, this as well, the literature is all over the place. There's some evidence for headaches that have either that have some parasympathetic symptoms flavor to them. It's actually a 2B recommendation by the I forget which society. It's like the Neurologic Society of the States or something. I don't know, but I forget what it is. But it's a 2B recommendation for them. The issue is that in practice, when you do them, the ganglion is never quite where it's supposed to be. And so when you are trying to put either you can do it just topically with a syringe and you just put the fluid up their nose, essentially. You don't know if it's getting there. It's not quite the same as leaving a topical application for 10 minutes with a cotton applicator, but the issue with a cotton applicator is you may not be getting to the right spot. The other issue is that I feel like you have to read the room. I've gotten like enough COVID swabs up my nose that I think that if somebody offered me another thing up my nose, I would say no. But then again, it's an option and you can offer it to patients and see what they say. Some people swear by it and some people say it's total garbage. The literature is honestly mixed. Intranasal ketamine. So this is the last little thing I want to say. So there was a kind of another cute trial that came out in 2019. I'm surprised it didn't get traction in FOAMed, honestly. It was a prospective RCT, single blind again, because you can't really, it's really hard to blind for an intranasal something or IV compared to an IV something, but prospective RCT, single blind, convenience sample, 53 patients. They gave 1 to 2 doses of intranasal ketamine, and then 30 minutes later offered a second dose if they were not sufficiently treated. And they compared that to IV Maxaran and diphenhydramine. And the treating physician had the option to add Dex and ketorolac in the control arm, so to the IV Maxaran. What's interesting is that they used the numerical pain scale to compare. There was a clinically significant change in both of the treatment arms, slightly higher for ketamine, but not significantly so between the two. And this was designed as a superiority trial. So therefore, actually failed to demonstrate superiority for ketamine. When you looked at who received ketorolac and who actually received Dex, actually the majority of the control arm received ketorolac as well. So what this might suggest is that ketamine treatment intranasally may be either equivalent or at least potentially not inferior to Maxaran plus diphenhydramine plus ketorolac. Obviously, you would need another study to confirm that, but I thought that was kind of interesting. It's like a quick, easy, dirty treatment to do if you can just do intranasal. They can wait from the side. You don't even need a nurse to put an IV in. You can just do intranasal ketamine, have them sit on the lazy boy and reassess an hour later, and potentially they can go home. That sounds like an awesome treatment to me. And so I really hope that we see further studies in this regard. There was a really kind of poorly done retrospective study in headaches in children that I'm referring to here that was quite positive actually. And so I hope they do a better study in children to see what the application could be there as well. So my conclusion to this talk is that starting as I was reading about all of this, I ended up on this deep, dark dive into pain medicine and debatable treatments that we do or don't do. And I could talk for like hours and hours on this. So I see that we're running out of time anyways. It's really easy to do pain management wrong. So it's easy to do it wrong. It's hard to do it right for a variety of factors that we discussed. Dosing and reassessments can be difficult. There's many systematic issues that are not playing in our favor. And I would encourage many of you to start asking your patients whether their pain is relieved and would they like more medication, and if not, why? There's some interesting ALTOs coming up in the world. They are very interesting. There's a number of them that seem to be useful, but again, they're not the answer to everything. And if you learn how to use opioids appropriately and actually talk to your patients about whether they would be happy to use them or not, they can be very useful medications. And then finally, honestly, make the effort to learn nerve blocks. Underused skill, super satisfying to not have to take opioids from a patient's point of view. And I'm looking forward to that procedures day being organized next year to the Future Chiefs. I'm gonna check in, that's all I had. Oh wait, no, actually I have more. I have just a poll. Can you guys see my poll? Oh no, wait, here. Okay, I sent out a poll because I want to see what you guys think. And then we'll finish on that. We're done, I promise. So you're now viewing the questions. So have you caught yourself underdosing pain meds is the first question. Do you see a role for low-dose ketamine in the ED, and will you use it? Will you try to integrate regional anesthesia into your practice? And the last one is, do you offer occipital nerve blocks, sphenopalatine ganglion blocks as a second-line migraine treatment? So I think you guys should be able to see. Rob, can you confirm that you guys can see?
So I see questions, but is this supposed to be like?
Oh, there we go. Yeah, okay, so you guys should be able to answer. I see the results here. Okay, I think I have like 14 or 15 answers, so I'll just stop there. I think end poll and then share results. So have you caught yourself underdosing pain meds? It seems that most people are pretty confident that they probably have. I'm glad you recognized it. So now try to put something that you learned today into practice and try to catch yourself and act on it. Do you see a role for low-dose ketamine in the ED? Will you use it? 14 people, 100%. said yes, proven efficacy in the right context. I'm curious if those are all residents or if those are staff, because obviously if the staff aren't comfortable, then the residents won't be using it. Will you try to integrate regional anesthesia into your practice? Yes, but not comfortable with most modalities. Want to learn? Great. So my procedures sim will definitely be happening next year. Do you offer occipital nerve blocks as a second line migraine treatment? It seems that we're pretty mixed and similar to kind of how I am. You know, better than nothing. I'll offer it to them. It doesn't take that much time, but meh. That's all I had. Thanks for listening. Maybe I'll go to the chat and see